Today, I am going to show you exactly what testosterone does in women, why low testosterone is one of the most underdiagnosed hormonal conditions in medicine, and what addressing it actually looks like. Millions of women over 40 have lost something they cannot quite name. It is not just energy, it is not just libido, it is something deeper than that, a drive, a vitality, a sense of engagement with their own life that used to be effortless and now feels completely out of reach. And almost every single one of them is told the same wrong thing, that it is depression, that it is stress, that it is just what getting older feels like, that they should consider an antidepressant and learn to manage their expectations. What almost none of them are told is that their testosterone may be critically low and that testosterone is just as essential to the female body as it is to the male body. Let me start by dismantling a myth that has caused an enormous amount of unnecessary suffering. Testosterone is not a male hormone. It is a human hormone. And in women, it is produced in the ovaries and the adrenal glands and plays a critical role in virtually every system that determines how vital, capable, and engaged you feel in your daily life. In the female body, testosterone supports lean muscle mass and the ability to build and maintain it, which is why women with low testosterone often find that exercise stops producing results no matter how consistently they train. It supports bone density. Testosterone is one of the primary drivers of bone mineral deposition, and its decline is a significant contributor to the accelerated bone loss women experience in their 40s and beyond. It drives cognitive function, memory, focus, mental sharpness, and the processing speed that allows you to think clearly under pressure. It regulates energy at the cellular level, not the surface level energy that a cup of coffee provides, but the deep, sustained drive that gets you through a full day without feeling like you are running on empty by 2 in the afternoon. It supports cardiovascular health, immune regulation, and the production of red blood cells. And yes, it drives libido, not just in terms of sexual desire, but in terms of the broader appetite for life, for connection, for ambition, for the things that make you feel like a fully realized version of yourself. When testosterone is optimal, most women do not think about it. When it is significantly low, they feel it in everything. Here is where the underdiagnosis problem becomes most costly, because the symptoms of low testosterone in women are real, significant, and consistently misattributed to other causes. Persistent fatigue that does not respond to rest or sleep improvement, loss of motivation, and not situational lack of interest, but a pervasive flatness where things that used to matter simply do not generate the drive they once did. Difficulty building or maintaining muscle mass despite regular exercise and adequate protein intake. Increased body fat, particularly around the midsection, that does not respond to diet changes. Cognitive changes. Brain fog, word-finding difficulties, reduced sharpness and processing speed that feels like a cloud that will not lift. Mood changes, flattened affect, increased irritability, a low-grade emotional dullness that is often indistinguishable from depression on the surface, decreased bone density on DEXA scan without an obvious explanation, and reduced libido, which in women is often the last symptom to be taken seriously and the first one to be dismissed as psychological or relational rather than hormonal. Every single one of these symptoms has a legitimate hormonal explanation. Every single one of them can be the presenting sign of low testosterone, and every single one of them is routinely attributed to stress, aging, depression, or lifestyle without anyone ever running the one test that could identify the actual cause in 30 minutes. Testosterone in women peaks in the mid-20s and begins a gradual decline from there. But the rate of that decline is not fixed, and several factors can dramatically accelerate it. Chronic stress and elevated cortisol are among the most significant because cortisol and testosterone share a precursor molecule, and when the body is under sustained stress, it prioritizes cortisol production at the expense of testosterone synthesis. This is the same cortisol steal we discussed in the hormone video, and it means that a woman in her late 30s who is chronically stressed may have the testosterone levels of someone significantly older. Oral contraceptive use is another factor that is rarely discussed openly. Combined oral contraceptives suppress ovarian testosterone production and increase sex hormone binding globulin, a protein that binds testosterone in the blood and renders it biologically inactive. Women who have been on oral contraceptives for extended periods sometimes find that their testosterone levels and their free testosterone, the fraction that is actually usable by the body, are significantly suppressed even after discontinuing, and that recovery requires deliberate support. Surgical menopause, removal of the ovaries, causes an immediate and dramatic drop in testosterone production, often more severe and more sudden than the gradual decline of natural menopause, and it is consistently undertreated. And aging itself, combined with declining ovarian function during perimenopause and menopause, produces a sustained reduction in testosterone output that compounds the effects of every other driver. This is one of the most important things I can tell you if you suspect testosterone may be part of your picture. Standard testosterone testing in women is almost universally inadequate. Most standard panels measure total testosterone, the total amount of testosterone in the blood, without measuring free testosterone, which is the fraction that is actually available to your cells and tissues. Total testosterone can look normal while free testosterone is critically low because high levels of sex hormone binding globulin are binding the majority of available testosterone and rendering it biologically unavailable, which means a woman can have a normal total testosterone result on a standard lab panel and still be functionally testosterone deficient in a way that is driving real significant symptoms. A proper testosterone assessment in women includes total testosterone, free testosterone, sex hormone binding globulin, and DHEAS, the adrenal precursor that supports testosterone production, evaluated together as a system, not as isolated numbers. And the interpretation has to account for where a woman is in her cycle, her age, her symptom picture, and the clinical context, not just whether her number clears a reference range threshold. This is why a woman can leave her doctor's office having been told her testosterone is fine and still feel exactly like someone whose testosterone is not fine, because it probably is not. When testosterone deficiency is properly identified and addressed in women, the response is often one of the most striking clinical improvements I see. The energy returns, not a stimulated, caffeinated kind of energy, but a genuine, sustained vitality that feels like coming back to yourself after a long absence. Motivation and cognitive sharpness improve in ways that patients often describe as dramatic. The fog lifts, the drive returns, and the engagement with their own life that had been quietly disappearing begins to come back. Muscle response to exercise improves, body composition shifts, and the frustrating plateau that made working out feel pointless begins to resolve. Testosterone optimization in women requires a careful, individualized approach. The doses involved are significantly lower than those used in men. The delivery method matters, and monitoring needs to be consistent and comprehensive. Done correctly, it is one of the most impactful interventions available in women's hormone medicine. Done incorrectly, with inadequate testing, inappropriate dosing, or without monitoring, it can create its own set of problems, which is exactly why this is a conversation that needs to happen with a clinician who understands the full hormonal picture and has specific experience with female hormone optimization, not a generalist who runs a single total testosterone and tells you everything is fine. If you have been feeling like a dimmer version of yourself for longer than you can remember, if the drive, the energy, the motivation, the sharpness that used to define you have been quietly disappearing, and nobody has ever checked your testosterone, that needs to change. Because you may not be dealing with aging or depression or stress. You may be dealing with a hormone deficiency that has a name, a test, and a treatment, and that responds when properly addressed in ways that can genuinely change everything. We have a free testosterone quiz at defynaturalaging.com that will give you a meaningful starting point for understanding whether this is part of your picture. Go to defynaturalaging.com, take the testosterone quiz, and let's find out what your body has actually been trying to tell you.